नमस्कार, मैं डॉक्टर चैतन्य हूँ और हम देख रहे हैं हमारा ECG ट्यूटोरियल 26. This is my channel Critical Care Basics, and in this channel we are discussing ECG tutorials. This is ECG tutorial number 26, and in this three subsequent lectures we are going to talk on mechanisms of tachyarrhythmias. So let's go into the topic directly. Mechanisms of tachyarrhythmias. There are three mechanisms by which arrhythmias can develop. First is enhanced automaticity, second triggered activity, and third re-entry. In this lecture we are going to focus on enhanced automaticity. For understanding what is enhanced automaticity, we should first know what is automaticity, as we have already discussed in multiple lectures, especially in my first lecture in ECG tutorial 1 about action potential of heart. Automaticity is that property of certain cardiac cells which have specialized into so-called conduction system to generate their own action potentials without getting external impulse. Right? So automatically they start generating action potentials. This is properties most rapid in the SA node. Therefore SA node rules the heart. Therefore we say the heart is in sinus rhythm. Then there are arterial cells. The second fastest is the AV node. Then the bundle of His, Purkinje fibers, and lastly the ventricular muscle. So recapitulate what we have already learned in my first lecture on action potential. The action potential of SA node and the action potential of the contractile myocardial cell. Action potential of SA node is slightly different in the sense there is no resting membrane potential. So this flat line in phase 4 depolarization is absent. What you get is a maximum diastolic potential from which slowly maximum diastolic potential is around -60, from which slowly the membrane potential rises due to entry of sodium ions through the funny sodium channels. And as the membrane potential reaches -40, which is a threshold, calcium gates open up and lot of calcium comes inside, causing depolarization. As we all know, why this is called as depolarization? Because we are going away from the polar potential or so-called resting membrane potential. As soon as the cell is fully depolarized with a membrane potential around +20, the calcium gates close and potassium gates open. This causes efflux of potassium ions outside, causing gradual repolarization till this point of -60 millivolts is reached again. So this cycle continues. This is the normal automatic membrane potential of SA node cells. This property of automaticity is fastest in the SA node, therefore SA node rules. If any pacemaker generates its own rhythm, the faster rhythm of SA node suppresses this rhythm. And so the SA node rhythm, sinus node rhythm rules, which can activate action potential at a rate of 60 to 100. Arterial cells at 55 to 60, AV node at 45 to 50, His bundle 40 to 45, bundle branch again 40 to 45, Purkinje cells 35 to 40, and lastly ventricular myocardium 30 to 35. If successively the pacemakers do not work, then the lower pacemakers with lower rates take over. Increased automaticity can be divided into enhanced normal automaticity, in which the normal automaticity or the automaticity due to the pacemaker cells is enhanced or faster, while abnormal automaticity is that automaticity which occurs within non-pacemaker cells or normal myocardial contractile cells. This can occur in acute ischemia like in myocardial infarction, especially when there is reperfusion. Suppose a patient is having acute heart attack and angiography and angioplasty was done and there is reperfusion, blood flows back with a gush into the artery again. There is reperfusion arrhythmia which can be due to abnormal automaticity following reperfusion. Congestive cardiac failure can also give rise to enhanced abnormal automaticity. But enhanced normal automaticity can occur due to increased automaticity in the pacemaker system. For example, stimulation of sympathetic nervous system will cause heart rate to increase. This can occur following hypovolemia or sepsis, both of which stimulate the sympathetic nervous system. Or inhibition of the parasympathetic nervous system. For example, if you give atropine, the heart rate will drop down. Lastly, if there is ATP depletion, because all these channels, many of them are active and they require energy in form of ATP. So if there is ATP depletion due to severe hypoxia or ischemia, then these channels cannot work and they can generate abnormal automaticity, enhanced automaticity. Digoxin toxicity and hypokalemia are also known risk factors. In this figure, the top one chart is the chart of normal action potential. We have seen maximum diastolic potential of minus 60, and this is the phase 4, then phase 0 and phase 3. As we all know, there is no phase 1 and phase 2 in SA node action potential. If there is parasympathetic stimulation, the acetylcholine is released by parasympathetic nerve fibers which act on the muscarinic receptor. This causes decrease in the slope of phase 4. Phase 4 is due to slow entry of sodium channels. This is slowed down. At the same time, the NAK potassium pumps is acting more or made to act faster or more, therefore hyperpolarizing. The normal maximum diastolic potential is minus 60, it is hyperpolarized to minus 70. So we get a lower potential and a decreased slope of phase 4, causing decrease in heart rate. Opposite occurs in sympathetic stimulation. If there is, say, hypovolemia or shock, so sympathetic effect occurs due to noradrenaline released by the sympathetic nerve fibers and adrenaline secreted by the adrenals. These act on the beta 1 receptors, and beta 1 stimulation causes increase in the slope of the phase 4 depolarization, and there is reduced repolarization. The NAK potassium pump acts slower. So the maximum diastolic potential which has to be otherwise minus 60 comes to minus 50. So there is lesser current difference that has to be traveled, and the current difference is crossed at a higher rate, or the slope of phase 4 has increased, causing tachycardia. So enhanced normal automaticity is nothing but stimulation of sympathetic nerve fibers causing tachycardia. In essence, what happens is, if we have to have automaticity, increased automaticity, so either we have to increase the maximum diastolic potential, or we have to reduce hyperpolarization. Secondly, we have to increase the slope of depolarization, or we have to reduce the threshold potential. As we have seen, enhanced automaticity could occur due to one of these 4 factors. 3 we have already seen, increase in the slope of phase 4 depolarization, we have already seen. Decrease in the threshold, this can also occur for excitation, and lastly some combination. But in this, there is shortening of the refractory period. So can the refractory period be actually shortened? So we will learn more about this in triggered activity in my next lecture. In automaticity, we also have to discuss in short about what is called as parasystole. As the name suggests, parasystole is a parallel systole or parallel action potential. Parasystole is a kind of arrhythmia caused by the presence of and function of a secondary pacemaker in the heart which works in parallel with the SA node. Normally what happens, if there is an impulse generated elsewhere, SA node impulse is the fastest, so it suppresses any impulse occurring elsewhere. But suppose there is an entrance block, right? So which does not allow depolarization from the SA node to go towards the ectopic pacemaker. Then this continues as independent pacemaker and this continues as independent pacemaker, both working together, and they compete with each other to gain control of ventricular depolarization. Right? So parasystolic pacemaker can exist in both atria as well as in ventricles. We will see some examples of ventricular parasystole. The parasystole in ventricle could be fixed or modulated. Let's see some examples. Fixed ventricular parasystole or parasystole. Fixed ventricular parasystole occurs when an ectopic pacemaker is protected by entrance block, right? And thus its activity is completely independent from the sinus pacemaker. So sinus depolarization continues, but it is blocked. This wave cannot reach the ectopic pacemaker and it continues to generate its own rhythm. Hence the ectopic pacemaker is expected to fire at a fixed rate, right? And therefore on ECG the coupling intervals of the manifest and the ectopic beats will wander through the basic cycle of the sinus rhythm. For example, what is coupling interval? Coupling interval is the interval between the QRS of the normal sinus wave and the QRS of the ectopic. What is happening here is this ectopic focus is generating a regular ectopic rhythm. This is a ventricular ectopic because QRS is wide, there is no P wave, and T wave is directed opposite to the QRS complex. So these are the three criteria for calling this ventricular ectopic. We have not discussed ventricular ectopic so far, but nevertheless, these are the three criteria by which we diagnose a ventricular ectopic. It is wide, bizarre, the QRS and the T wave are directed in opposite directions, and the P wave is absent. So this is ventricular ectopic. Because this ventricular ectopic's shape is same, this is coming from one single focus, right? And you can see that it is coming at a fixed interval. So this is fixed parasystole, right? What happens now? This parasystole as well as the sinus node both try to compete each other for activation of the ventricles. For example, this is the ectopic, that ventricular ectopic generated by the ectopic focus. Ideally, it should have also been the case here. The ectopic should have come here earlier, but here the ectopic fell on the refractory period, and so it could not create an ectopic. Similarly, here it should have come here, but it is not coming here because here it is again landing on the refractory period. So what happens is, if it lands earlier anywhere, it can create this type of rhythm. You can see the coupling interval, that is interval between the sinus QRS complex and the QRS complex of the ectopic beat may change, because ectopic is coming at a fixed rhythm, sinus node is firing at a fixed rhythm, but the intermingling is not fixed depending on whether the ventricle is refractory or not. So you can see the coupling interval is 680, here 520, then 400. So the coupling interval is changing, but PVC interval is fixed at 15-60 milliseconds. Another example, this is a ventricular ectopic, this is the sinus node, but QRS is looking wide because there may be some aberrant conduction. So this is sinus beat, this is ectopic, this is second ectopic, this is third ectopic. So ectopics can come at a fixed interval of say 600 milliseconds, or it could come into multiple of that fixed interval. For example, 600 is the fixed interval, or it could come at double the interval of 600 into 1200 or 1190. The presence of variable coupling intervals. The coupling intervals start from the QRS of sinus to QRS of ectopic. This keeps on changing, as you can see here. Inter-ectopic intervals, that are simple multiples of common denominator. So this is a minimum common denominator. This ventricular ectopic is constantly firing at a rate of say between 2 there is 600 milliseconds. But sometime when the ventricular impulse comes, it comes in the refractory period, so it cannot take over the ventricle. It cannot depolarize the ventricle, so it is not seen here. So another ventricle comes, that comes at a multiples of that fixed interval. Another thing is, you can see fusion beats. These are the fusion beats. There has been a mixture or fusion between the sinus beat and the ventricular beat. So this is fixed ventricular parasystole. But this pure parasystolic cycle length, for example, here it is about 1150 milliseconds, was prolonged by 30 milliseconds to 170 milliseconds by effect of intervening non-arm parasystolic premature contraction. So this was the parasystole. Here an abnormal ectopic has come, and therefore this is an abnormal ectopic, and this is not the part of parasystole. So it has prolonged, it has modulated or modified the intercycle distance by say 30 milliseconds or by 170 milliseconds, and so this is modulated parasystole. Thank you. This was about the automaticity. In next lecture, we will discuss about triggered activity. Thank you so much. If you are liking these lectures, please like, share and subscribe. Jai Hind.